Hey everyone, and welcome. So if you're a clinician in training, you've probably had it drilled into you that cystic fibrosis is all about the lungs. But its reach goes way deeper, especially into the gastrointestinal tract, and that's where things can get really tricky. Today, we're going to unpack one of the biggest GI challenges in CF, Distal Intestinal Obstruction Syndrome, or as you'll hear it called, DIOS.
Okay, let's just dive right in with a scenario you will absolutely encounter. Picture this. You're on call and a patient with a known history of CF comes into the ER. They're complaining of this cramping pain and it's localized to their right lower quadrant. Now sure, appendicitis is probably the first thing that pops into your head. But in this specific group of patients, what's that other diagnosis, that unique syndrome that needs to be at the very top of your list? That's exactly what we're going to figure out.
So here's our game plan. First, we're going to look at the big picture of GI problems in cystic fibrosis. Then we'll zero in on what DIOS actually is. After that, we'll get super practical with how you diagnose it. And finally, we'll wrap up with the really crucial stuff, how you treat it, and just as important, how you stop it from happening again.
Right, so Section 1. I really can't stress this enough. That same genetic glitch that causes so much trouble in the lungs, it's doing the exact same thing all the way through the gut.
It really all comes back to that one faulty gene, CFTR. We all know it leads to that super thick, sticky mucus in the airways. Well, guess what? It does the same thing in the GI tract. And this isn't just some minor inconvenience. These tenacious secretions can literally form plugs, gumming up the works and paving the way for some really serious blockages. And that's exactly where DIOS comes from. It is a direct consequence of this GI mucus problem. And it's a condition you really only see in people with CF. And look at this number. It is not a rare thing. Depending on the study, it affects anywhere from 10 to almost half of all patients with CF. I mean, that's a huge range, and it's a statistic that should definitely have your attention.
Okay, so let's really get into the nitty-gritty. What exactly is DIOS, and how do you know which of your patients are walking around with a higher risk of developing a... The definition here is everything. DIOS is an acute problem, meaning it comes on suddenly. And the location? That's the real giveaway. It happens right at the ileocecum. That's the junction where the small intestine meets the large intestine. And it's caused by this thick, almost cement-like intestinal material that forms a plug. I want to be super clear, this is not the same thing as just being really constipated.
Now this right here, this is basically your clinical cheat sheet. Your suspicion for DIOS needs to shoot way up when you have a patient with a severe genotype, like being homozygous for the F508del mutation. Pancreatic insufficiency is another huge one. It makes sense, right? If you don't have the enzymes to break down fat, your stool gets a lot thicker and stickier. Dehydration, opioid use, those are classic triggers. But the biggest predictor of all, a history of a previous DIOS episode. If they've had it once, they're at high risk for having it again.
Okay, great. So we know what it is and who to watch out for. But how do you confidently make the call when a patient actually shows up with that classic abdominal pain? How do you solve that puzzle? Thankfully, you've got a really powerful framework to guide you. When it comes to DIOs, the diagnosis often hinges on finding a classic triad of signs and symptoms. If you can identify these three things, you are well on your way to nailing the diagnosis. And here it is. Number one is the patient story, that cramping pain, that feeling of being bloated and distended. Number two is what you find with your own hands on the physical exam. You can actually feel a mass down in that right lower quadrant. And number three is what you see on imaging. The X-ray shows a bunch of stool backed up in the last part of the small intestine. And here's a fantastic little pearl for when you're looking at that KUB. Don't just look for signs of a blockage. Look at the character of the stool itself. It has this very specific appearance, often described as bubbly or granular. When you see that, you should be thinking DIOS. It's a classic sign of all that air mixed in with the sticky and spicitated intestinal contents. Telling DIOS apart from just really bad constipation is probably the biggest diagnostic hurdle. So let's break down the key differences. DIOS hits you acutely. It comes out of nowhere. Constipation tends to be more gradual. The mass in DIOS is up in the right lower quadrant where the small bowel ends. In constipation, if you can feel a mass, it's usually farther down in the colon. And on the X-ray, DIOS traps stool in the small bowel, while constipation shows stool packed throughout the entire colon. These distinctions are absolutely crucial.
All right, you've made the diagnosis. Now the clock is ticking. We need to manage this obstruction. Let's walk through the step-by-step approach to treatment, and then we'll talk about how to stop it from ever coming back.
Okay, before you even think about trying to break up that plug, you have to stabilize the patient. These folks can get profoundly dehydrated, and their electrolytes can be all out of whack. So job number one, the absolute first step is to get IV fluids going and correct those abnormalities. This is totally non-negotiable. Now, for the blockage itself, we've got a tiered approach. If it's just an incomplete obstruction and the patient isn't vomiting, you can start with an intestinal lavage, basically giving them a solution like Golightly, either to drink or through an NG tube. But if the obstruction is complete or that lavage just isn't working, you escalate to a hyperosmolar contrast enema. Using something like gastrographin is great because it's osmotic. It pulls water into the bowel, which helps soften and break up that impacted stool. And surgery, that's really the last resort. You save that for cases that just won't clear, or if you see any red flags for something more serious like peritonitis. So, getting them through the acute episode is a huge win, but the job isn't done, because DIOS absolutely loves to come back. Long-term prevention is the name of the game. This almost always means starting a daily osmotic laxative, making sure their pancreatic enzyme doses are just right, hammering home the importance of staying hydrated, and just generally managing any underlying tendency toward constipation.
So there you have it, a deep dive into DIOS, a true CF-specific emergency. And that kind of brings up a final, really important question for you to think about in your own practice. What other diseases out there have their own unique syndrome-specific emergencies that you need to be aware of? You know, thinking like that, beyond just the common diagnoses for the general population, that's what really separates a good clinician from a truly great one.